Good afternoon, everyone. Welcome to this special webinar on COVID-19 prevention with monoclonal antibodies. My name is Ian Colbert, and I am the Executive Director of the Canadian Public Health Association, and I will be your host and moderator today. I would like to start by respectfully acknowledging that while we are coming together from all parts of Turtle Island, CPHA's offices are located on the ancestral, unceded territory of the Algonquin and Anishinaabe. They have been the guardians of this land for millennia, and CPHA is grateful for the example their stewardship provides. CPHA is committed to working with all First Nations, Inuit, and Métis people and their governments in realizing meaningful truth and reconciliation. Today, we are joined by Eric Pitters, who will share with us his personal story and why monoclonal antibodies could be a game changer for him. Our second guest is Dr. Brian Conway, the Medical Director of the Vancouver Infectious Diseases Center, as well as an assistant professor at in the Department of Pharmacology and Therapeutics at the University of British Columbia. Dr. Conway will share his knowledge about the science of monoclonal antibodies. Today's webinar is being recorded and will be posted on CPHA's YouTube channel early next week. If you have questions, please use the Q&A module to post them at any time during the session. It is now my pleasure to ask Eric to share his story with us. Eric, the floor is yours. You're on mute, Eric.
Okay, my name is Eric Pitters. I am a CLL patient, chronic lymphocytic leukemia. I've had it for 17 years, and this is a disease that can be managed. It's not curable, but is manageable. And I've been through a lot to be able to manage this disease. From a monoclonal antibody, certain drugs that have been used to treat my disease have been that particular rituximab, but this is a disease that can be controlled through new vaccinations or prevention or controlled by new vaccinations that are coming out. Monoclonal antibodies being one of them. The most recent one is that I've seen is Efficacy. There are some others, but the question here is always when to take it. And in my experience, you need to know what antibody levels you have before you do take it. And I paid $75 to Dynacare to have my spike tests looked at. And I'm over the top with 4 COVID vaccinations, over the top. So we decided to hold the Efficacy for a couple of months. So, but that's in a nutshell. If there's anything further you wish, I can certainly comment on it.
That's great, Eric. And it's a great way to frame for everyone kind of the importance of monoclonal antibodies when it comes to COVID-19 prevention and how there are these complexities to it. It's not a straight line for everyone. So it is now my pleasure to invite Dr. Conway to share his knowledge on today's topic. Brian.
Well, thank you very much for having me, Ian. And can people see my screen? Are we good?
Yes.
Okay. I should have made clear to Ian that my allegiances have changed slightly. I have great respect for the University of British Columbia, but I am now with the Faculty of Health Sciences at Simon Fraser University. And it's my pleasure to be with you here where it is still morning in Vancouver to talk about COVID-19 pre-exposure prophylaxis or prevention with monoclonal antibodies. So one of the things that we need to recognize is that the vaccines for COVID-19 have been our lifeline, and they work in a way that probably we couldn't have predicted before these vaccines became available. In this study published earlier this year, that is a summary of 51 studies over the first 15 months of vaccine administration, trying to look at their composite efficacy in all of the individuals to whom they were administered, we can see that they are highly effective. They prevent severe infection in 90% of cases. They prevent hospitalization in 97% of cases, whether it's hospitalization to a ward or hospitalization to an intensive care unit. And they are particularly effective in reducing mortality, perhaps by as much as 99%. So in the general population, the vaccines are highly effective. However, if we focus on sort of these blue bars here, the BNT is the Pfizer mRNA vaccine. And this is a study of 5.5 million people, 1.5 million of whom belong to a risk group. And this is meant to inform us about how effective the vaccine is if certain medical comorbidities are present. And the first side of the slide here on the left is showing us the efficacy of one dose of vaccine 1 to 3 months after its administration. And we can see that in certain populations, such as those that are immunosuppressed down here, the vaccine's efficacy is reduced to 24% and is at best 50% in cases of the various diseases, heart disease, diabetes, neurologic disease, kidney disease, morbid obesity, and the like. So this isn't surprising, since we know that this is a 2-dose vaccine, and that over time, if you wait too long after administration of the first dose, its efficacy is decreased. So if we look at what happens a couple of months after administration of a second dose, particularly in immunosuppressed individuals, the efficacy of the vaccine is reduced to 60% and is in the 70 to 80% range in the majority of individuals who have one or more of the comorbid conditions that are shown here. So vaccine efficacy is great, but it is possibly reduced in individuals who have a number of other issues that affect their body system, such as heart and lungs, or in whom their immune system is in some way depleted by an associated illness or its treatment. And if we look at this in a different way, in a composite of 61 studies published, or 63 studies published by the CDC, we can see that particularly in organ transplant recipients, the efficacy of the vaccine is significantly reduced and may be completely ineffective. In individuals that are on immunosuppressive therapies, this is equally true, although there is greater heterogeneity having to do with these immunosuppressive therapies being more or less immunosuppressive, affecting the immune system more or less significantly. Eric's comment about rituximab, which is a B-cell depleting agent, is one of the most immunosuppressive therapies that we have, and this would be expected to have a significant effect on the efficacy of the vaccine. Hemodialysis was thought to have an effect on vaccine efficacy, and that's true to some extent, but certainly not in all cases. And certain cancers, especially hematologic cancers here in dark blue, and CLL that Eric was mentioning is a hematologic cancer, would have an effect on vaccine efficacy. So if you have a hematologic cancer and you're on rituximab, one could expect the vaccine to have some efficacy, but this is a particular kind of situation where if you had some other intervention available that you would want to consider it to supplement the protection that the vaccine is providing, that may be less than would be expected than in the general population. So what about third doses of the vaccine? And this is a small Israeli study that is looking at a relatively small number of individuals. And here again, CLL, chronic lymphocytic leukemia, comes up. And what this is showing us is that after 3 doses of the vaccine, that the efficacy is about 50%. So not great. And in kidney transplant recipients, I showed you the transplant recipients are particularly susceptible to having reduced efficacy of the vaccine. You're at 53%. Vaccine is great in the general population, has done us well, has allowed us to progress through COVID world, but in certain populations, we need to think about other ways of preventing COVID. Now, in 4 vaccine doses in the world of Omicron, this is showing us the level of antibody that protects you against Omicron, whether it's with administration of the Pfizer mRNA vaccine or the Moderna mRNA vaccine. 5 months after a 3rd dose, vaccine efficacy is reduced here, protecting against Omicron. 1 week after a 4th dose, it is increased, and that is maintained for the subsequent week. But you can see that the level of protection against Omicron is about, in terms of measuring the amount of antibody, whether it's the Pfizer product or the Moderna product, is less by about 4 to 16-fold, less than the protection offered against the ancestral strain or the Delta variant that characterized the previous waves of the pandemic up until the wave that occurred over the recent holiday season. So here's another thing that may reduce vaccine efficacy is the evolution of new strains where the antibodies that are elicited by the vaccine are either less plentiful or less effective. So it's defining populations where we may need to intervene. Now, in the general population, how many people is that? So in the United States, if we look at all of these conditions, sort of blood cancers, individuals receiving chemotherapy, transplant recipients, people on dialysis, those on immunosuppressives, or those having primary diseases of their immune system, it's probably about 3% of the population, between 2.5 and 3. And if we look at the American data, looking at 2.7% of this population, assuming the general population that falls into this category, and they are vaccinated, this accounts for almost half of the hospitalizations. So these are individuals that potentially need our help. So the Evusheld that Eric spoke about, by its generic name, is a combination of 2 long-acting antibodies, tixagevimab and silgavimab, that I will refer to as Tixa and Silga for the rest of this presentation. These are 2 different antibodies that bind to 2 different parts of the spike protein of the virus. They're very potent. They retain activity against most variants of concern, though I'll describe this a little bit later. They have a half-life through a modification in their structure that makes them persist in the body for 6 or 9 months, perhaps even longer. They're safe and well tolerated. They've been studied for pre-exposure prophylaxis in individuals at risk of having decreased vaccine efficacy or increased risk of severity of COVID should it occur. It's an injection, 2 separate injections of 1.5 milliliters given intramuscularly as a single dose. So that's Tixa and Silga. So here's the SARS virus, the COVID-19 virus, on a cell that it binds to a receptor called the angiotensin converting enzyme type 2 receptor, or ACE2 receptor, and thereby, through this binding, it then penetrates into the cell. So Tixa and Silga bind to 2 different parts of the spike protein and prevent entry into the cell. So that is the mechanism of action of these interventions. Now, there was a large study called the PROVENT study that was published earlier this year in the New England Journal of Medicine. So in this study of Tixa and Silga, the objective of the study was to evaluate the safety and efficacy of a single dose, 2 intramuscular injections compared to placebo as a preventative agent for COVID-19 in selected populations. Population that was studied were individuals who were adults, who were at increased risk of an inadequate response to the vaccine or at increased risk of severe disease, that were not carrying any antibodies. So either if they'd had infection before, they didn't know it, blood tests were done to show that they didn't have antibodies, and a PCR test was done to demonstrate that they weren't infected at that particular point in time. So individuals with a prior laboratory confirmed coronavirus infection, SARS or MERS or COVID-19 itself, or who had received a vaccine or a biologic, a monoclonal antibody or what have you, were not included. Over 5,000 individuals were studied 2/3 receiving the active product, Tixasilga, and 1/3 receiving placebo. And the end point of the study is really looking for a symptomatic illness with a PCR test being positive for COVID-19, occurring within 6 months of receiving either the active drug injection or the placebo injection. Safety data are going to be collected on an ongoing basis. And I will just tell you that as of right now, there's no significant side effects that would limit the use of Tixasilga that have been noted to date. So the population that was studied, so first 43% population was over 60, and being over 60 in and of itself allowed you to participate in the study. Immunosuppressive disease or taking immunosuppressive medications was an entry criteria. 75% or more had that, or had diabetes, heart disease, lung disease, kidney disease, liver disease, or some other significant underlying illness. And this was a population that was largely Caucasian, 73%, with 17% Black, few other races being represented other than the Hispanic here. Now, in terms of the underlying diseases, heart disease, 8%, obesity in and of itself was a criteria for entry, 41%, 43%, as I've shown you before, were over the age of 60, and then 5% or so each with liver, lung, or kidney disease or being immunosuppressed. The mean age in both the treatment and placebo groups was in their early 50s. Almost half of the population was female. I've discussed the racial distribution before, and the body mass index was relatively high, owing to the fact that just obesity in and of itself was a criteria for participation in the study. So in the first 5 months of the study, 150 days, there were 8 cases of symptomatic PCR confirmed COVID-19 infection in the treatment group and 17 in the placebo group. And remembering that there's twice as many people on Tixasilga as in the placebo group, this is about a 4-fold reduction. So a hazard ratio of 0.23 of getting infected if you got treated compared to placebo. And a few things can be seen here is that the protection of Tixasilga over 5 months is sort of maintained. A few cases early on, and then no further cases were observed in the subsequent few months. And you can see a steady accumulation of new cases over the 5 months of observation that are shown here. Now, and this study's almost done now, so new data sort of adding a 6th month here is that there were 3 additional cases in the treatment arm and 14 additional cases in the placebo arm. So you can see that as you go on here, more and more cases in the placebo arm, just a few more here in the Tixasilga arm. And we had hoped that the benefit would last at minimum 6 months, perhaps longer. And based on these data, this seems to be the case. So the primary efficacy endpoint was met, 77% reduction at 5 months. And going out to 6 months, the benefit is a bit greater at 83%. And the difference between treatment and placebo is highly statistically significant. So it worked in terms of the endpoints of the clinical trial. Next question to ask is, among the different population defined by age, sex, race, and underlying diseases, is there a population in whom the treatment didn't work? And this line here, this is called a forest plot. And this line here, if you're to the right of it in terms of the benefit or lack of benefit that is observed, then this favors treatment. And if you are to the left of it, it favors placebo or shows that the treatment doesn't work. And you will see that any subgroup, whether it's based on age, sex, ethnicity, underlying diseases, obesity, and the like, all of these points are to the right, showing a benefit of Tixasilga in any of the subgroups that were enrolled in the study. Now, the study was not powered or designed to look at hospitalization, severe disease, or death. So with that as a little bit of a limitation, presenting these data to you, of individuals who required hospitalization, intubation, or the like, so severe COVID, or who died from COVID. There were no cases in the treatment group. Severe COVID, there were 5 cases in the placebo group and 2 deaths. So this is not obviously statistically significant, but it kind of adds to the body of evidence generated in the study that this particular treatment was effective. Now, all of this work was done prior to the arrival of Omicron. So it was the ancestral strain, alpha, beta, and going into delta. And this is a depiction of the spike protein. And you can see sort of in orange here that these are the genetic changes that delta carries compared to the ancestral strain. So you see a few genetic changes, but if you look at Omicron, and obviously not going through these genetic changes individually, you can see that there's a lot more orange. So this is a genetically very different spike protein that carries at least 30 distinct amino acid changes. Now, the Omicron variant does not have many changes, genetic changes in other parts of the virus that would affect the efficacy of antivirals that are directed against, not against the spike protein. So this is reassuring. But if you're thinking of things like monoclonal antibodies, Tixacilga, it is directed against the spike protein. So it begs the question of whether all of these genetic changes will reduce the efficacy of this particular intervention. Now, beyond Omicron, we're now into subvariants, BA1, BA2, BA3, and we're now to BA5 that's dominating disease spread in the United Kingdom at this particular point in time. And you can see that there's, of all the BA1s, 2, 3, there's 32 mutations in common. There's some unique mutations that affect, that are, particular to BA1, 2 or 3, and BA2 is potentially more infective, so it'll cause more disease. So there's a whole series of subvariants that we need to consider in evaluating whether monoclonal antibodies will remain effective in the world of Omicron. So this has been studied in a test tube, often with live virus, and in some cases with pseudotype viral-like particles. So an in vitro system that's a surrogate that will help us determine whether the monoclonal antibody will remain effective against this variant or subvariant. And we can see here, this is the actual number of the concentration of antibody that's required to inhibit various strains. And this is the reduction, if any, in the efficacy of Tixacilga against these particular substrains. So for BA2 that I mentioned was being more infective, a 5-fold reduction in efficacy isn't going to be of significance clinically. For BA1.1, an almost 200-fold reduction, that could be significant. And there's some controversy with respect to BA1, quite distinct from BA1.1. In the pseudotype assay, it looked as if there was high level of resistance. And in other types of live virus assays, there really wasn't. So BA1.1 for sure, BA1 maybe, other Omicron variants, we don't expect a reduction in the efficacy of Tixacilga. But obviously, this is the kind of thing that it's very nice to do this in a test tube, but it would be amazing if we had real life data. And this is a preprint, not yet subjected to peer review, of a study done through the Veterans Administration database to address this issue. So this was done between January and April of this year, and it examined 17 or 1,800 individuals in the VA system in the United States that had received Tixacilga, and initially they were compared to a large group of controls, 250,000, but this was sort of honed down in trying to identify controls by propensity score matching. So what this does is it takes the individuals who got Tixacilga and tries to compare them by, match them, I should say, to individuals who didn't receive it, who had similar immunosuppression, comorbid diseases, or other conditions that would be associated with higher likelihood of decreased vaccine efficacy or increased severity of COVID. So the final group that's part of the study is 1,733 individuals on Tixacilga and 6,300 controls. This is a VA study in the United States, not surprising that it's 91% male, mean age 60, high 60s, mainly Caucasian, 77%. And in contradistinction to the registrational trial I just described, this is a highly vaccinated population. So 75%, 3/4 had received their 3 shots, and 70% were overweight or obese. In terms of the comorbid conditions that they had, they're listed here: cancer, asthma, coronary artery disease, heart disease in and of itself, diabetes, hypertension, liver disease. And by design, you will see that all of these comorbid conditions are pretty well matched between the control group and the cases. And the same applies to people on immunosuppressants or being immunocompromised in the between 70 and 90%. So they're matched. If we look at the outcomes here, so the composite outcome in terms of in these groups having COVID, being hospitalized for COVID, or succumbing to COVID or any other cause during the period of observation, in the overall cohort, there was about a 70% protective effect in Omicron era for Tixacilga, immunocompromised, 70%, severely immunocompromised, still pretty good at 50% protection, and more like 70 to 75% in the non-immunocompromised. And if we look at the individual outcomes rather than the composite outcomes, so infection, hospitalization, mortality, still a significant benefit. And in terms of an evaluation of the robustness of study design, they looked at urinary tract infections, expecting these to be matched in the 2 groups because this is not an intervention of interest. This is not a condition of interest or one on which we intervene. And it's reassuring to see that it was pretty much the same in the 2 groups. So this is very reassuring. And if we look at the accumulation of cases over time in the Tixacilga group, you can see that the difference is sort of occurs early in the first 30 days and is maintained for 100 days of observation, with the understanding that this is a study that was just done January to April. So we're not going to have much longer follow-up than sort of the 100 days. So we need to sort of remind ourselves that COVID vaccines are our lifeline, but their effectiveness is reduced in individuals that have impaired immune function. This includes people who are immunocompromised because of underlying health conditions or on medicines that suppress the immune system. Tixacilga is a long-acting antibody combination that was designed to address this unmet need. The clinical trial program is robust, and we only talked about prevention right now, but early treatment is being considered with this agent. And in the PROVENT study that I described to you, it was effective in reducing the risk of infection by 77% at 5 months and 83% at 6 months. There were no events on Tixacilga and no deaths. So this is very, very reassuring. In general terms, Tixacilga remains active against variants of concern. The ones that we're worried about is BA1 and for sure BA1.1. And this has now been licensed in a number of countries, including Canada. So the use in Canada, what's on the label, is it's indicated for individuals who are 12 years of age and older, weighing at least 40 kilograms, who are immune compromised or unlikely to mount an adequate immune response, or the small group for whom COVID-19 vaccine is not recommended. No storage issues, regular fridge. It should be given at a dose of, as I've mentioned, 1.5 mLs of each, 2 separate intramuscular injections. Because of the data that I shared with you for BA1.1 and maybe for BA1, a double dose should be considered to overcome the decreased susceptibility. If someone has had a history of allergy to anything that's contained in the product, obviously it shouldn't be shouldn't be given. And if there's an increased risk of bleeding, then this should be given with some caution, because this is an intramuscular, not a subcutaneous injection. So it's 2 separate vials here, 150 milligrams, stored unopened in a regular fridge. Don't freeze, don't shake, don't do nothing. And the dose is a uniform dose with the caveat for the subvariants that I mentioned. So it really is not, everyone gets the same dose. So there isn't, and it's prepackaged, fairly easy to get. So who actually is going to get this? So in the United States, they've had a number of meetings, and it really, this is emergency use authorization criteria, and sort of looking at individuals who have cancers, hematologic malignancies, including chronic lymphocytic leukemia, especially if they're on rituximab. So this totally makes sense. The transplant recipients kind of make sense. Individuals who are on significant immunosuppression or have underlying disease that affects their immune system, and individuals who are on certain drugs. And this is just outlining in a bit more detail, subgroups that might be eligible. So here's what I think about what you should be doing in Canada. Is number one, price is no object. All of these medications have been pre-purchased by the Canadian government. So they cost a lot, I am sure, but in terms of how we're going to decide to use it, the idea of whether this medication is more or less effective at this point in time doesn't enter into the discussion. The limitations at provincial and territorial levels, the entities that will distribute it, are really the logistics, how it's going to be distributed, and establishing guidelines. So from discussions that have already occurred, there's general consensus among transplant recipients that should get it, immunosuppressed patients, and without going into a lot of detail, is we divide immunosuppressive therapies into 4 categories. Category A are the most immunosuppressive of all. So rituximab is in there, stem cell transplants and the like. Most other monoclonal antibodies are Bs. So that's a group that we should think about. Cancer patients, especially hematologic malignancies, we should think about. In individuals that just have comorbidities, so people who have issues of body mass index and heart disease in and of themselves, and that there hasn't been any clear decision there. There's, in the PROVENT study, they enrolled men and women who lived in congregate settings, including college dorms. It wasn't a large proportion of the population, but certainly that's something to think about. And in our inner cities, where congregate settings are imposed on people, where there's high risk of transmission of transmissible agents to begin with in respiratory virus season, is this a community where, for instance, if people in a given building, there's a certain number of cases, say 10 cases among 50 individuals in that building, is there some benefit to administering Tixacilga to individuals who live in that building who aren't infected, especially if they have comorbid conditions? So that's kind of the hierarchy as I see it going forward. And I think I'll stop there, and I'll be happy to address any questions that might arise.
That is great, Brian. I know much more about monoclonal antibodies than I did half an hour ago, so I greatly appreciate that. So we do have a few questions, a couple in the chat. So if I say them wrong, you can correct me. Why does a spike antibody test result of seronegative after rituximab not make you eligible for Evusheld in most provinces in Canada?
Well, it should. And I think that rituximab, someone with CLL and rituximab, I mean, Eric is the poster child, if I can use the word child, for receiving Evusheld, the poster person, the poster gentleman. No, I mean, I think right now, people are in Canada are being very cautious. Authorities are being way too cautious, to my mind, in terms of rolling this out. And as I say, as much as you don't like, you say, well, this stuff is expensive. Well, yes, but it's already paid for. And the last thing I would hope to see in the headlines in a few months is that we threw out a whole bunch of Evusheld that had expired.
Excellent. Brian also questions, I'll shorthand it. What is their goal for how many eligible patients to receive Evusheld?
That's a little hard to say. So I think, 100,000 would be good. It sounds like a lot, and I think it's a lot more than that. But I think if we get there, that'll be good. There are that many Canadians that would benefit from it very easily without us giving it much of a second thought.
Super. Then Barbara asks, should you have antibody testing before getting Evusheld?
If it was quantitative, yes, but the test, meaning if it measured how much antibody, but if I had a transplant recipient who had received vaccine and has detectable anti-spike antibodies, epidemiologically, we know that transplant recipients are the ones that respond the least well. So I would probably, in the context of a study that's trying to understand and hierarchize patients, maybe. But otherwise, I don't think a positive test would preclude the use of Evusheld in an individual who is otherwise a very strong candidate to receive it. That's how I view it.
Great. Next question is there a minimum level of platelets necessary to receive Evusheld?
So this goes back to first principles in medicine, having not a lot to do with COVID, is that we don't like to give intramuscular injections to individuals that have 20,000 platelets or less. So that would be the same cutoff. Somewhere between 20 and 50, I would give it a little bit of a second thought. And if you're really concerned and they really need Evusheld, that might be an indication for a platelet transfusion.
Very good. Not sure if you can answer this question, but Maureen asks, when will it be available in BC?
Oh, I'm sad to say that it actually is available. It's just really hard to get.
There you go. Any suggestions on?
Well, I had a meeting with the people who run transplant programs, and they're being very cautious. They're saying maybe to a small number of people, and it's hard for me to sort of get through get through this. And I come back to the issue of let's not worry about cost, and that sort of is a barrier that people still have, that this is very costly, and it probably is, but it's paid for. I've said that 3 times, it's going to, if anything, it will have no benefit or benefit. It will not harm, and the epidemiologic data is really getting very strong. I think as the VA study, and that's very new, and I will caution us. I said it's a preprint, which is a new evolution in the medical literature, that people are able to pay a certain sum of money to get what looks like a paper put out in public. It's not been peer reviewed yet. But with that caveat, it's a strong study. And as those data come out, I think we'll be reassured of the potential benefit.
Great. So next question is, if you had a cardiac arrest, VTAC and VFib, thought to have occurred as a result of the CLL medication, LBRUT nib, is Evusheld contraindicated?
Okay, I'm reading it. Ibrutinib is a class B immunosuppressant. It's not like rituximab, but it's up there. Is Evusheld contraindicated? No. Short answer to that is no.
Great. Then Jamie was asking, I think he just wrote, what about B4 and B5? I guess efficacy against those variants?
Well, it's being looked at right now.
Okay. Helen is saying, I have CLL and I am on Ibrutinib. My hospital said I am in the second rollout. Will there be enough Evusheld for me?
Oh, yes, there's tons of Evusheld out there. And here again, I'm trying to understand first rollouts, second rollouts, third, whatever. Let's do this. I think this is where what I'm sensing is it really, you know, the federal government has stockpiles of this stuff. And it's really up to the provinces to request it and the people who are in charge of various programs to become convinced of the benefit of it, set up the infrastructure. And this is an intramuscular injection, one in each hip. So this isn't hard. This is how you treat syphilis. And there's no barrier. Someone has syphilis, they come in, we take the stuff out of the fridge, we do the 2 injections, and they go on their way. So the logistics of this aren't going to be very hard.
Great. Then Heather is asking, if you are on immune globulin weekly subcutaneous treatment, do you need an Evusheld shot? I was treated with rituximab 18 months ago and have now antibodies from 4 COVID vaccines.
This is really at the limits of what our knowledge is. That's a situation that I would discuss with an individual practitioner. 4 vaccines is good, excellent. The immunoglobulin, the IVIG, will not protect you against COVID. So that is a bit different than the whole issue of Evusheld. Rituximab is the most potent, you know, that's a class A drug. It's very immunosuppressive. So that gets you to the top of the list. So without knowing everything else and not wanting to get into providing medical advice by Zoom, this is a person who really should be seriously considered.
Okay. So Graham is in Ontario and writes that he has CLL, but has not received any treatment for several years. I'm told I'm not an Evusheld candidate. What is the rationale behind this?
Well, here again, this is up to these organizations that are making these, you know, these oncologists and other specialists that are trying to hierarchize who should get it first. I wouldn't necessarily use the term not a candidate, because we know that hematologic malignancies in and of themselves reduce vaccine responsiveness. That's the group of malignancies in whom we see that reduced efficacy. So I would try to dig into this a little bit more. I wouldn't use the word not a candidate.
Okay, very good. So are people who have been treated for CLL and are in remission likely to be considered to be immunocompromised?
On a spectrum, yes. On a spectrum, yes. I mean, active CLL is more immunocompromised. Getting Ritux is certainly more immunocompromised, but it certainly is certainly isn't the opposite of immunocompromised, which is immunocompetent. So when we go from immunocompetent to immunocompromised, it's a spectrum. It isn't a black and white thing. So they're on that spectrum a little bit more towards the immunocompromised than competent.
Excellent, thanks. John is writing, in Ontario, cancer patients on rituximab are eligible for Evusheld, but not others like GPMPA, vasculitis, MS, and RA, etc. However, those in Quebec, BC, and New Brunswick are eligible. Can you comment, and how do we change eligibility in Ontario and the others?
Well, welcome to the Canadian Federation. I mean, you know, we have 13 jurisdictions, and that this is reflective of exactly, you know, the opinions of individuals. I mean, if we take this into the vaccine world, why is it that if you're 60 in Ontario, you're eligible for a 4th shot, whereas it's 70 in British Columbia? I mean, let's just make sure that what I would do is I would ask, you know, in a very non-judgmental, open way, I would ask the experts to talk to each other. I would say, look, if I move to this other province, I'm getting it, and here I'm not. So, you know, could someone explain to me in a very, you know, in a way that I can understand why this is?
Excellent. Another question, are people who have been treated for CLL and are in remission likely to be considered to be immunocompromised?
Yeah, again, yes. I mean, you're on that spectrum. You're not as immunocompromised as you potentially once were, but I would still put you on the spectrum.
Great. Then Brian asks, how should eligible patients approach their specialists who have not yet reached out to them, or worse, haven't heard about Evusheld?
So this is the same, yes. So talk to your specialist, talk to your family doctor, and if they don't seem to want to engage in this discussion, I think it's perfectly appropriate to be empowered and to say, look, there's people in the province that know about this stuff, and with respect, could you refer me? Because I'm taking care of my own health, and I want these questions answered. I accept the fact that you don't know the answers because you're not a specialist or you're not, whatever. I accept that fact, but someone else does. Can I see him or her?
Very good. And I think this is in a similar vein, but I'll ask the question anyway. I have CLL, but not under treatment. Do I qualify for Evusheld?
You should be considered. Maybe not top front of the line, but we need to create a line. We need to do this much more assertively than we have up until now in Canada, for sure.
And what seems to be the last question at the moment is from Barb. You indicated there was an unlimited supply, but we've been told the supply is limited and prorated by province.
Okay, so that's a distribution thing. It's an issue of, you have to ask, you have to have a place to put it, you have to have a system. So when people say it's limited, with every respect, it's that you haven't set up the infrastructure to get it. Eventually it will be limited. But no, there's enough of this stuff to go around for now.
Excellent. That is good news, and we're dealing with systems that are under strain, so it's not completely unsurprising that the logistics haven't all been ironed out. But they also now have had time to get their ducks lined up.
Yeah, I think that's a good point, Ian. Let's not I hope I do not want to sound too critical. The system has been strained beyond anything that it could have prepared for, like the healthcare system in general. Let's state that. However, we still have a responsibility to try and do the best we can, and let's encourage each other to do so.
Absolutely. And on that very positive note, I am going to thank you, Brian and Eric, for being with us today. I think this has been an extremely educational session for everyone. I know I've learned a lot, so that's great. I will just share with everyone that CPHA has been trying to stay up to date on what the different provinces are doing and saying, and posting some resources to a page on our website. So feel free to share that around. And as I had mentioned before, this webinar has been recorded, and so the recording will be posted to CPHA's YouTube channel as soon as possible. Thank you again for joining us today, and enjoy the rest of your day. Stay well.